Hi, Dr. Pelto here. It's been a few years since I've done a video on Haglund's deformity, and some of the treatments have changed. I've had to do less surgery for this condition, so I want to talk about some of the newer non-surgical options that have really worked for our patients. If you want to get the link to these slides and also my treatment sheet, this is the same thing I give patients in the office. I'm going to put a link underneath this video for you. So let's get into it. This is the same presentation that I give to my patients. So typically, the patients that I see have had a bump in the back of their heel for a number of years, usually been 2-3 years. They've had it, but they come in when it starts to hurt. When it gets much more swollen, much more painful, they want treatment. Many times patients that have come in, they've tried stretching, they've tried open back shoes because hitting the back of the shoe on that big bump can be painful. And they may have even done physical therapy or iced or anti-inflammatory. So I'm going to go over the whole kind of treatment process. And it tends to impact their life because it hurts when they go downstairs. It tends to hurt when they hit something on the back of their heel and they can't be as active. That's why they want treatment. So if we look at what the Haglund's deformity is, it's basically these bumps. You see these bumps in the back of the heel? Now, these bumps might not be painful because it's basically a bump and skin. So they tend not to be as painful. The ones that I see tend to be much more swollen. So the reason you can tell if they're painful or not, you just push on them. If they're painful, they're inflamed. And there's a couple of areas that can be painful. In my experience, if you draw this little almost like checker tic-tac-toe box on the back, there's different areas. I find that the upper poles right here on the upper part of the heel tend to be more painful, and sometimes right in the middle. And this is caused by this bump in the back. Do you see this bump? This bump that kind of sticks out at the back of the heel, and then occasionally it can produce a sac of fluid, which is the painful part. So I want to be very clear. You can have this bump, you can have, without pain. A lot of people don't have pain for a long time, but then it gets painful. Now, the challenge with this type of condition, this bump in the back, the Achilles that comes down, is that there's not the best circulation to this area. So if you look, the Achilles tendon comes down the back of the heel, and it kind of goes into the heel. So you got a bone with a white piece of tissue. Now, white tissue doesn't have the best circulation. That's the whole problem. And in the past, we've had to do surgeries to shave down the bump. But now there's a newer treatment that's called shockwave that can be used to increase the blood flow to the area to help this to go away. It's not instantaneous. It takes a while, but it does work. It works pretty predictably unless there is a break in the back of that spur in the back. So when you talk about Haglund's, there's a couple of other terms you can use. Some people call this an insertional Achilles tendinitis. That's why here's the insertion of the Achilles, because the Achilles comes down and it pulls. So with the Achilles, there's two areas that the Achilles can hurt. It can hurt above the insertion, which is right here, or at the insertion. So if you have Achilles tendinitis, you may also have the Haglund's if there is a bump. So some people have the bump, some people don't have the bump. Regardless, it tends to hurt a lot. Okay, and the way you can find that is you just push and you can have the pain, and the darn stuff doesn't go away. There are some treatments you can try before you get into the shockwave. The most important diagnostic exam we tend to do in the office is we do an X-ray to see if there's this big bump right here. This is the bump. This is an example of surgically, if we're going to think about removing it. This is kind of approximately where we would remove the bump and then put these anchors in here to reattach the Achilles. But as I mentioned before, if this is not swollen, it might not be painful, and you could live with this indefinitely. So we're trying to avoid more of the surgery. Once again, another example here of the Achilles tendon on the back of the heel where it's kind of inflamed, and another example of an ultrasound where it inserts in. This is kind of like a side view. You'd be looking at this right here. Comes down, inserts. So the best diagnostic exam, in my opinion, is an X-ray to look for the bump, and then the ultrasound. The reason I like the ultrasound is you can see the ultrasound, the area of the Achilles as it comes down, it should look like celery, and it should all look like the tissue around it. If there's whiteness black in here, that means there's swelling or a diffusion in the Achilles. And I like to do an ultrasound prior to treatment, and then I like to do ultrasound after the treatment, such as the shockwave, and I can see if the changes in the tissues happen. So I put this together to help my patients. It's called a Haglund's Treatment Evaluator. I have these for everything that I do. There are certain treatments that are most effective, others that are least effective, and the focus is on reducing pain, reducing tightness, and reducing stress going through the foot. And most patients, they try this stuff underneath the yellow line before they come and see me. So you've probably tried these things if you're watching these videos. Oral anti-inflammatories, Motrin, ibuprofen, icing. If you haven't tried contrast baths, you could try that. It's a bucket of ice water for 5 minutes. Dip your foot in there, a bucket of hot water, and then bucket of ice water. Topical creams. You may have tried stretching, over-the-counter arch supports, or a heel lift specifically, because if you lift the heel up, you're going to reduce some of the pull on that Achilles. Strapping the foot, compression sleeve, losing weight. All these things underneath the yellow line are okay, but if it's inflamed, it tends not to be sufficient enough. Now, you might ask, why can't I just do a cortisone injection? You don't like to inject the cortisone in the heel because it can cause a rupture of the Achilles. Now, on a very rare chance, I occasionally do it right up here, if it's only, because if the Achilles comes in and inserts here into the middle third of the heel, and occasionally, if there's only one little spot, I might inject it with a little cortisone, staying away from 80 to 90% of the Achilles insertion, do a little bit right there, and put them in a walking boot. Very rarely do I do that. Most of the time these days, I'm doing something called shockwave therapy. So if you haven't heard of shockwave, what shockwave is this treatment right here. It uses a little bullet that goes back and forth, hits the tissue, creates sound waves, and kind of starts your own growth factor, and we call it neogenesis. Recently, I did a surgery on a patient with one of these, and we did shockwave first, and she wasn't able to tolerate it. She wanted the spurt. But when I did the surgery, I realized that there was just a lot of really good blood flow in that area, new blood called it neogenesis of vessels, new vessels in there. So it does work well. It just wasn't effective enough because she had a really large bump. That's kind of an example of the shockwave. Occasionally, we'll also put in another type of an injection called an amniotic injection, where you put that, just helps speed up the healing. So I find this now has really made it so I have to do much less surgery. The speed bridge is where you kind of shave it down and you re-anchor it in there. I don't have to do that a lot. Now I have the shockwave. It works really well. I've only had one patient in the last year that needed the surgery because this was so effective. So if you're considering surgery, you might want to consider shockwave first. Other things that you can do as well, you can do home therapy, night splint. So usually patients get what we call the Pelto special, which is they do a morning stretch, they do foam rolling on the back of the calf, and then a night splint for 3 hours a day, or they can sleep with it. What the night splint does is it reduces the pull in all the tissues back here along with the foam rolling. So if it reduces the pull here, it's going to reduce the pull there. It doesn't always take care of all the pain, but it can be part of it. And then if you're seeing me, what you'll do is you do 3 sessions of shockwave, 3 to 6. It depends if you have it for a longer period of time. Then you go to 6 weeks of PT. Okay. And this is the way you get rid of the pain. And then to reduce it from coming back, I'm going to make sure you're an appropriate shoe. My favorite sandal is like an UFO sandal. And then you might do orthotics as well, depending if you have pronation, which would make the pull increase on the Achilles tendon. I would avoid, when you're recovering from Haglund's or Achilles tendonitis, doing a 0-drop shoe, because that could make things worse. So you might need an orthotic, things like that. But this is my traditional treatment now for Haglund's deformity. I think it's something that if you are dealing with it, I'm going to put a link, as I mentioned before. I'm going to put a link to this, my what I call a treatment sheet. It's the treatment sheet, the presentation, and everything that I give the patients in the office. If you want to learn more. If you have any questions, post them under this video. I'll try to answer it for you. I have a couple of other previous videos I did on Achilles a couple of years ago. I used to do more surgery, but now with these non-surgical treatments, it tends to work better. Okay, thanks.